Hello, my name is Anne Marie Valenti, and this session will focus on pregnancy and heart disease. I do not have any disclosures. So I'd like to start this session with a question, and I'll read it and then read the potential answers. Which of the following hemodynamic parameters decreases during pregnancy? Is it A, heart rate, B, stroke volume, C, plasma volume, D, systemic vascular resistance, or E, cardiac output? So thinking about that, the answer is D, systemic vascular resistance. And I'd like to start by just reviewing what we know about the hemodynamic changes in pregnancy. So on this figure, you'll see the duration of pregnancy in weeks on the x-axis, and then I've listed the change of these parameters from pre-pregnancy values on the y-axis. So looking at each one individually, if we start with plasma volume, shown here in red, women double their plasma volume during pregnancy, but it really happens late in pregnancy at the end of the second trimester, beginning of the third trimester, as shown here. Stroke volume also increases, shown here in blue. This happens much earlier, and women can accelerate their stroke volume by 30% really in the beginning of the second trimester. Heart rate also increases, shown here in orange. It's estimated that women's heart rates increase about 10% prior to pre-pregnancy values, and that sustains throughout pregnancy. Cardiac output, shown in purple, also surges almost up to 50%, the pre-pregnancy values. The timing of that is again early in the earlier part of the second trimester. So notice that all of these parameters so far that we've talked about increase during pregnancy. But the parameter that decreases is that systemic vascular resistance. You can see that here in green. And you can think about this as the placenta being the best afterload reducer that we know of. So this is why certain women with certain cardiac conditions actually do okay throughout this time in pregnancy at a lower SVR. I'd like to point out that during the postpartum period, things change very rapidly, and this is a time of great concern for us when we have women with significant cardiac disease. Now, over the past 2 decades, there have been several risk scores developed for women with heart disease during pregnancy. We know that women who have heart conditions have more complications regarding arrhythmias and heart failure symptoms during pregnancy. And several studies have showed about 15% chance that that will happen. There are several common factors that have been identified that would make this more probable in women, and these include prior cardiovascular events, poor functional class, ventricular dysfunction, and left ventricular outflow tract obstruction. And it's important to note that in these studies, specific conditions were underrepresented or not included, conditions that would be considered very high risk, such as pulmonary hypertension or aortopathies associated with connective tissue disorders. You can see in this figure, it's just showing you some of the different classification scales that's been used to highlight that the World Health Organization class, which is shown here in green, really does have the greatest area under the ROC curve. Now, looking at the data specifically, I've just highlighted 3 such studies for you with the maternal cardiac factors that have been associated with an increased risk of an adverse event in pregnancy. This first column shows the CARPREG study that was published by Sam Su and colleagues in 2001 and looked at over 500 pregnancies in women with heart disease. They recognized 4 risk factors as shown here: prior cardiac event, decreased functional class or cyanosis, varying degrees of left ventricular outflow tract obstruction, mitral valve disease or aortic valve disease, as well as systemic ventricular dysfunction. The next column is showing you the Zahara weighted score that was developed in over 1,300 pregnancies, and this was an effort that included 60 countries. You can see some of the factors are quite similar, such as the left ventricular outflow tract obstruction, the advanced New York Heart Association class, or history of arrhythmias. However, other factors were noted here, and they're weighted so that women with mechanical heart valves have a very high weighted score for an adverse event in pregnancy. The last column is showing you the World Health Organization class, which I find very useful. This separates women into 4 classes based on their level of disease. So class 1 would be low-risk patients, those that have had mild forms of conditions such as pulmonary stenosis or possibly a repaired atrial septal defect. What I'd like to focus on are those higher risk patients that are class 3 and 4. This figure is taken from a document published by the European Society of Cardiology. I find this reference particularly useful when thinking about women during pregnancy that have heart disease. You can see here listed are the class 3 patients that would have a significantly increased risk of morbidity and mortality, and those include women with cyanotic heart disease, mechanical heart valves, systemic right ventricle, such as patients with transposition that have undergone an atrial switch procedure, Fontan procedure, and then connective tissue disorders such as Marfan syndrome with an enlarged aorta or bicuspid aortic valve with an enlarged aorta. Women that fall into the class 4 category must be cautioned that pregnancy is very high risk and often contraindicated. These include women with pulmonary hypertension, severe systemic ventricular dysfunction, severe symptomatic aortic stenosis, and we'll talk more about that, native severe coarctations, and again the aortopathies with a greater degree of aortic dilation. I'd also like to share with you this very recent publication in which Sam Su's group went back and looked at now almost 2,000 pregnancies in women with underlying heart disease and have recently published the CARPREG-2 study. You can see here that I've listed the predictors that they found and the number of points as far as the weighted score. If we focused on the highest risk, those would be, not surprisingly, women who've had prior events or arrhythmias, New York Heart Association class 3 or 4 or cyanosis, or those women with a mechanical heart valve. It's important to consider other women that are at higher risk, such as those with ventricular dysfunction, high-risk left-sided valve disease, pulmonary hypertension, coronary artery disease, and high-risk aortopathies. The last group of patients are newer factors that they found, those women that presented late in pregnancy or that presented with significant heart disease who had not undergone a prior intervention. This other panel is showing you the central illustration from their article, just highlighting the importance of looking at the woman's history, physical exam, specific cardiac lesions, integrating imaging to help us define the risk, and then determining the delivery of care along with the obstetric team. So now I'd like to move on to question 2. A 28-year-old woman who is 29 weeks pregnant presents with increasing shortness of breath over the past 2 weeks. Transthoracic echo shows rheumatic mitral stenosis with a mean gradient of 12 millimeters of mercury and a heart rate of 120 beats per minute, which is sinus tachycardia. What is the best initial management strategy? Is it A, urgent mitral valve surgery, B, urgent balloon valvuloplasty, C, urgent delivery of the baby by cesarean section, D, initiation of a beta blocker, or E, initiation of anticoagulation? So the answer here is D, initiation of a beta blocker. And I use this case just to illustrate the importance of caring for women with valvular heart disease during pregnancy. In general, we know that stenotic valvular lesions are not as well tolerated as regurgitant lesions during pregnancy. And if you go back and think about those hemodynamic changes, we can understand why. For example, if you take the left-sided heart lesions, such as mitral stenosis, as pregnancy progresses and the heart rate rises, there's reduced time for diastolic filling, which may result in increased left atrial pressure and subsequent pulmonary edema. Aortic stenosis runs into problems when you have that increased cardiac output and women can increase their end diastolic pressure. So I'd like to talk about both of these conditions a little more in depth. So thinking about women with mitral stenosis who undergo pregnancy, it's helpful to look at the 2014 American Heart Association American College of Cardiology Guidelines for Management of People with Valvular Heart Disease, because there's a specific section that highlights treatment for women that are pregnant. Here are the recommendations. you can see that it's a Class 1 recommendation to use anticoagulation in women with mitral stenosis with atrial fibrillation, unless anticoagulation is contraindicated. A Class 2A recommendation is that beta blockers are required for rate control in these patients, and that was the answer to our prior question. A Class 2B recommendation is that diuretics may be reasonable for pregnant women with mitral stenosis if they have heart failure symptoms. And recognize that there is a Class 3 indication of harm in that ACE inhibitors and angiotensin receptor blockers should not be given to pregnant women due to the risk to the fetus. Now, looking at women with aortic stenosis, there's some recent data from the ROPAC investigators that helps us understand their risk during pregnancy. This involved 96 women with aortic stenosis, and about 2/3 of these women had moderate degrees of aortic stenosis with peak gradients between 36 and 63 millimeters of mercury. The other third of patients had severe aortic stenosis with a peak gradient documented above 64 millimeters of mercury. Of this group of women, 21% were hospitalized at some point during their pregnancy. There were no deaths in this cohort. Hospitalization was more common in women with severe AS, and it was highest if you had symptomatic severe aortic stenosis. It's also important to note that 35% of women with severe aortic stenosis had low birth weight infants. Here is the forest plot from that study looking at risks for hospitalization, and you can see highlighted here the greatest risks are women that present with signs or symptoms of heart failure and those with greater degrees of severity of their aortic stenosis. Now, considering invasive management in these women, we're going to look back at those 2014 guidelines for valvular heart disease. And it is recommended that we really only intervene if women are refractory to medical therapies. So looking at each of the individual lesions, for women with severe symptomatic mitral stenosis, they may be candidates for a percutaneous mitral balloon commissurotomy. However, if their morphology of the valve is not favorable, they may need to undergo mitral surgery. And this is really reserved to women that are in advanced New York Heart Association Class 3 to 4 heart failure despite best medical therapy. For women with severe symptomatic aortic stenosis, again, we would only do an intervention directly on the valve if they have New York Heart Association class symptoms 3 to 4, or if they have hemodynamic deterioration. And lastly, occasionally you may be confronted with a woman who has severe valvular regurgitation that is very symptomatic. And the indications for operation would be only if they have refractory heart failure symptoms, really stage D, despite best medical therapy. More and more women are getting pregnant who've had prior heart valve surgery. There was a recent investigation by the ROPAC investigators looking at this, where they were able to examine 212 women who'd had mechanical heart valves put in, compared to 134 women who had bioprosthetic heart valves. And what was remarkable was that mechanical valve thrombosis occurred in 10 women, 5 of which occurred early in pregnancy, in fact, in the first trimester, and all of them occurred when they were switching from one form of anticoagulation, heparin, to another. The rates of heart failure were similar in both groups, those with mechanical valves and those with bioprosthetic valves, and the maternal mortality was similar, just between 1% and 2%. So as we manage women with prosthetic heart valves in pregnancy, we can look to the 2014 valvular heart disease guidelines to guide us. I've listed some of the recommendations here. Warfarin is recommended for all pregnant women with a mechanical valve to achieve a therapeutic INR in the 2nd and 3rd trimesters. Warfarin should be discontinued with initiation of unfractionated heparin before a planned vaginal delivery in pregnant patients with a mechanical heart valve. Low-dose aspirin once daily is recommended for pregnant women in the 2nd and 3rd trimesters with either a mechanical or a bioprosthetic valve. Now, one of the newer recommendations is that in women who require a dose of warfarin that is less than or equal to 5 milligrams each day, they may continue on their warfarin throughout pregnancy, specifically during the first trimester. However, if the dose of warfarin needed to achieve a therapeutic INR is greater than 5 milligrams, they must be switched during the first trimester, and there are 2 potential switches listed here to go to dose-adjusted low molecular weight heparin at least twice daily with frequent monitoring of the anti-10A levels during the first trimester, or doing dose-adjusted continuous unfractionated heparin during the first trimester. To summarize the management for anticoagulation of women with mechanical heart valves during pregnancy, I've listed this figure taken directly from the heart valve guidelines that shows you the different class recommendations. Listed here in green is class 1, just highlighting the importance of frequent monitoring. And just to reiterate, if you can keep the baseline warfarin dose less than 5 milligrams per day, women may stay on that throughout pregnancy until timing of delivery when you switch to a heparin product. If their dose is more than 5 milligrams, you need to switch to a heparin-based product for the first trimester, remembering to add aspirin in all women in the second and third trimesters. Dr. Nishimura, who authored these guidelines, has subsequently published other summaries, and I've listed some of the points here that he emphasizes. Unfractionated heparin is in general a poor anticoagulant. There is a high risk of thrombosis. And vitamin K antagonists are best for the mother. However, there's a very dose-dependent relationship of complications. The use of low molecular weight heparin requires meticulous monitoring of the anti-10A levels. And we must remember to convert to continuous IV unfractionated heparin prior to a planned delivery. That is, in practice, if a woman comes in fully anticoagulated on a vitamin K antagonist, she requires a cesarean delivery for fetal protection. This illustration is from a recent meta-analysis from Seattle looking at the different risks of anticoagulation to both the mother, shown in this column, the fetus, shown in this column, and combined risk to either mother or fetus here. So this just highlights that vitamin K antagonists are the most protective for the mother with the lowest risk, however, can be very dangerous for babies. However, low-dose warfarin specifically has a shared risk of around 20%. It also highlights various strategies for the other heparin products and is a good reference to have. Now I'd like to just switch and talk for a few minutes about women with Marfan syndrome. These are women that we are seeing more and more that present during pregnancy. There was a recent study looking at 94 women with Marfan syndrome who had 227 pregnancies, and this is through the National Registry of Genetically Triggered Thoracic Aortic Aneurysm and Cardiovascular Conditions, or GENTAC registry. In these 94 women, 10% experienced a pregnancy-related aortic complication, and I've listed them here. 4 had a type A aortic dissection, 3 had a type B aortic dissection, 1 had a coronary artery dissection, and 2 had rapid aortic growth. Interestingly, the highest risk to these women was in the immediate postpartum period, and surprisingly, 3 of the 8 women who had a dissection were unaware of their diagnosis at their time of presentation. So to think about management of these women, we look to the thoracic aortic guidelines, which tell us that pregnancy does increase the risk of long-term aortic complications in these women. So class 1 recommendations include the importance of counseling women about their risk of aortic dissection and the heritable nature of the condition with strict blood pressure control throughout pregnancy. An additional class 1 recommendation is monthly or bi-monthly echo measurements of the ascending aorta in women with dilated roots or ascending aortas. Now, when you look at the class 2A recommendations, it does talk about management with regard to women in this category, in that it's reasonable to replace the aortic root and ascending aorta if the diameter is greater than 4 centimeters in Marfan syndrome. That's specifically in women prior to pregnancy. And as far as delivery, in general, we do not recommend cesarean section for women with cardiac disease for cardiac indications. However, these guidelines do have a class 2 recommendation that fetal delivery via cesarean section is reasonable if women have significant aortic enlargement, dissection, or severe aortic regurgitation. I'd like to move on to question 3. This is a 22-year-old woman who is 25 weeks pregnant, presenting with dizziness. On evaluation, her pulse is 150 beats per minute and blood pressure is 70/40 millimeters of mercury. An electrocardiogram confirms atrial flutter. What is your initial management? A, intravenous adenosine. B, intravenous beta blocker. C, oral calcium channel blockers. D, intravenous amiodarone. Or E, DC cardioversion. I believe the answer here would be E, DC cardioversion, and the reason is that she is significantly hypotensive at the time of presentation. In thinking about arrhythmias in pregnancy, we recognize that pregnancy may trigger pre-existing arrhythmias, or arrhythmias may manifest for the very first time. And this increased arrhythmia burden is probably due to a combination of the hemodynamic, the hormonal, and the autonomic changes that take place during pregnancy. In considering medical therapies, it's important to remember that the lowest effective doses should be used, often in consultation with an electrophysiologist. However, you can do electrocardioversion if there's hemodynamic instability. We reserve catheter ablations for those situations when medical therapy is ineffective. SVT is the most common arrhythmia in pregnancy, and AVNRT may be responsive to vagal maneuvers, adenosine is safe, or metoprolol. Verapamil and digoxin are generally avoided if WPW is present due to a risk of rapid accessory pathway conduction. And it's important to recognize that atrial fibrillation and atrial flutter are really less common. So if women present with this during pregnancy for the first time without structural heart disease, it's important to look for etiologies such as thyroid dysfunction or a pulmonary embolus. Now, ventricular arrhythmias are very rare without structural heart disease. And one of the groups of women that we see are those with long QT syndrome, and it's important to continue their beta blocker throughout pregnancy, labor, delivery, and postpartum. For your reference, I've included this figure from an article which is a review of antiarrhythmic drugs in pregnancy. And it's important to point out that this classification of safety of drugs during pregnancy with a letter as the FDA classification was replaced at the end of 2014 by a new pregnancy and lactation labeling rule. So you will see those letters now phased out, and the newer rule, which requires that several categories as far as risk during pregnancy as well as lactation will be developed. Let's go on to the last question. This is a 30-year-old woman with a history of peripartum cardiomyopathy and a left ventricular ejection fraction of 30%. She returns 2 years following the birth of her child. She desires a second pregnancy. She is asymptomatic, on no medication, and her echocardiogram reveals a left ventricular ejection fraction of 30%. What is your recommendation? Would it be A, proceed with the pregnancy, B, start an ACE inhibitor and proceed with pregnancy, C, obtain a cardiac MRI, and if her ejection fraction is improved, she can proceed with pregnancy, D, proceed with pregnancy with echocardiograms every trimester, or E, counsel against pregnancy? Well, here I would advocate that the answer would be E. This woman should be counseled to avoid pregnancy. She has a very abnormal left ventricular ejection fraction, and that must be recognized. Peripartum cardiomyopathy is a major cause of pregnancy-related deaths in the United States. The definition of it is that it's an idiopathic cardiomyopathy which presents with heart failure, secondary to left ventricular systolic dysfunction, presenting toward the end of pregnancy or in the months following delivery, where no other cause of heart failure is found. The women cannot have a prior history of heart disease, and this diagnosis must be confirmed by echocardiography with a left ventricular ejection fraction less than 45%. It's interesting to consider the geographic variations in presentation, just highlighting that in some regions where peripartum cardiomyopathy is common, the major presentation occurs postpartum. The pink here is is in the early postpartum period, 1 to 3 months, and the green is 3 to 6 months postpartum. And this would be the variation that you see in somewhere like South Africa, whereas if you look in the United States, up to a quarter of women are presenting while they are still pregnant. There has been a lot of work done looking at the etiologies for peripartum cardiomyopathy, and it's an interesting process to think about. This is some work done by Karen Siwa. Just looking at women during normal pregnancy, we know that there are physiologic changes that affect the heart, so that there is a pregnancy-associated left ventricular hypertrophy that develops. Now, most of those women after pregnancy revert back to normal physiology. However, there are multiple things that may act as a mechanism to continue that pathway down to a peripartum cardiomyopathy. I've listed them here. They involve things like viral antigens, stress-activated cytokines, autoimmune or genetic responses, as well as increasing apoptosis or prolactin production, which I'll talk about in a minute. Once you have peripartum cardiomyopathy, a certain number of women do go back to having a normal ejection fraction. Even if their ejection fraction normalizes, they still may have abnormal contractile function. However, another group of patients go on and have irreversible dysfunction, as we saw in that woman in the case that was presented, and those are at very, very high risk for subsequent pregnancies. This is some work that's been done looking at the vascular hypothesis that's involved with peripartum cardiomyopathy. And this involves several pathways. One is a mouse model looking at STAT3 transcription factor deletion. And with that, you get reduced expression of genes that protect against these reactive oxygenative species. Those would lead to an increase in the molecule known as cathepsin D. This is a peptidase which cleaves prolactin into a different formulation that is something that will promote apoptosis and could promote the development of a peripartum cardiomyopathy. A second pathway involves an angiogenesis pathway where the placenta is excreting S-FLT, which affects the VEGF pathway and again may cause endothelial dysfunction. So you will see in management guidelines the use of bromocriptine, which then blocks prolactin secretion, and in this case, those women do not seem to develop peripartum cardiomyopathy at the same rate. There's been some recent data looking at prognosis in women with peripartum cardiomyopathy. This has been highlighted by the IPAC registry, Investigations of Pregnancy-Associated Cardiomyopathy. Recently published, this involves 100 women with peripartum cardiomyopathy, and they had echocardiograms at baseline, at 2, 6, and 12 months postpartum. The endpoints that these investigators were examining were death, transplant, or the need for mechanical circulatory support, such as an LVAD. And what was recognized was that 13% of women had an event or a left ventricular ejection fraction less than 35% at 1 year postpartum. Looking at the data, no subject with a left ventricular ejection fraction less than 30%, as shown here in red, or a left ventricular end diastolic dimension greater than 6 centimeters recovered. The European Society of Cardiology has recently published in their heart failure guidelines the management for women with peripartum cardiomyopathy. So you can see in this schematic, firstly, to assess for any cardiopulmonary distress, and then confirming the diagnosis, you go down whichever pathway is appropriate. That is, with severe distress, you have to think about quickly optimizing preload, oxygenation, considering inotropes or vasopressors, delivering the baby, and whether or not there's a need for mechanical circulatory support. You can see highlighted here again is the potential for bromocriptine. In women who present without cardiopulmonary distress, your management strategies are going to depend on whether or not they're still pregnant, where you use a certain set of medications, or in the postpartum period where you can add back agents such as ACE inhibitors and spironolactone. Bromocriptine again should be considered, and thinking about long-term heart failure therapy for these patients. So it's important to recognize the severe morbidities and mortalities that are associated with peripartum cardiomyopathy because women do have future risk during subsequent pregnancies. This is some work done by Yuri El-Kayem and colleagues looking at women who had peripartum cardiomyopathy and had a subsequent pregnancy. In this panel, the pink bars illustrate women who had previously recovered their LV function prior to the next pregnancy. The blue bars highlight those who had not recovered their function at the time of the next pregnancy. So you can see, even in women who have recovered their function, there was still a 20% chance they would have heart failure symptoms, greater than 20% decrease in their left ventricular ejection fraction, and importantly, 14% which had persistent left ventricular dysfunction. For women that have persistent LV dysfunction when they go into the subsequent pregnancy, very high rate of symptoms, over 40%, with a 31% chance of persistent dysfunction and a 19% chance of mortality. This is a schematic by Dr. El-Kayem's group just talking about counseling for these women. That is, even in those with complete recovery after their last pregnancy, they need to understand there's up to a 20% chance of a relapse. Although the rate of recovery is higher, there is still morbidity and mortality. For those with persistent left ventricular dysfunction, again, as was noted in our question, we want to avoid pregnancy due to the very high risk of poor outcomes. Lastly, I'd just like to share with you that there is some exciting work being done looking at genomics regarding women with peripartum cardiomyopathy. This was a study looking at 172 women who had had peripartum cardiomyopathy, and they were able to sequence 43 genes with variants that have been associated with dilated cardiomyopathy. And what Dr. Ware and colleagues found was that in 15% of women, they had a variant in the titin gene, and it was in these women that at 1 year out had lower left ventricular ejection fractions. So it's there that I'd like to summarize and say there are dramatic hemodynamic changes that occur during pregnancy. Most forms of cardiac disease do not preclude pregnancy, but they do pose an increased risk to the mother and to the fetus. Established risk factors for adverse maternal outcomes include prior cardiac events, poor functional class, cyanosis, ventricular dysfunction or left ventricular outflow tract obstruction, and women with mechanical heart valves, pulmonary hypertension, or aortopathies. Please remember that women with valvular heart disease really do require special considerations and look to the valvular heart disease guidelines for management. And women with peripartum cardiomyopathy must recognize their significant risk if they choose to go on and have future pregnancies.